Okay, this is our lecture on the peripheral vascular system. This is also covered under Module E. We got a lot of information under Module E. This information is found in Chapter 38 of your Lewis text. So, with peripheral vascular alterations, we're going to look at Buerger's disease, Raynaud's disease, arterial ulcers, arterial thrombosis, and also arterial occlusive disease. To begin, when we talk about peripheral artery disease, it's the main cause of peripheral artery disease is atherosclerosis. And we've talked about atherosclerosis before, but what atherosclerosis does in the vessels is that it causes a hardening of the vessels with plaque formation, and as a result of both of those, the individual has a narrowing of the arteries. As a result of this atherosclerotic changes, the person has can develop tissue damage as a result of the arterial occlusion. As we know, our arteries are responsible, play a part in blood flow, allowing blood flow to our extremities and throughout our body, and carrying oxygenated blood to various parts of the body. And what we typically see with peripheral artery disease is that it typically affects the lower extremities. As I mentioned before, make sure you pay attention to the figure on 893, and it shows you the typical anatomic sites of atherosclerotic lesions, and the person typically has pain distal to the site of occlusion. So most clients, as it says here, seek treatment for a characteristic leg pain that's known as intermittent claudication. And with intermittent claudication, this is a pain that a person has when they're walking for maybe even short distances, and they describe this pain as a cramping, burning pain in the muscles, and as a result of that, it causes the person to have to rest. And typically the pain of intermittent claudication will relieve itself within 10 minutes. However, they describe this pain as being reproducible, which means if the person starts to walk again, do any type of exercise, then the pain will begin again. So with peripheral artery disease, we're going to talk about the manifestations and also the collaborative care associated with peripheral artery disease. We're just talking about the diseased arteries. So before we talk about that, if we can talk about the leading causes again, we see that the four major causes of peripheral artery disease are smoking, hyperlipidemia, hypertension, and diabetes mellitus. So again, if we're going to treat peripheral artery disease, we are going to have to help this person to do some lifestyle modifications in controlling if they smoke, if they have high cholesterol levels, maintaining healthy blood pressure, and maintaining healthy blood glucose levels. With peripheral artery disease, however, when we assess this patient, the skin color and temp, the person tends to have a coldness or a coolness associated with the extremities that are affected. And as I said, we typically see it affecting the lower extremities, but they'll have a coldness, and it makes sense that the person is going to have that coldness because it's deficient blood supply to that part of the body. And when you note, when you're doing an assessment on your patient, you always want to make sure that you're comparing sides, because a person could have peripheral artery disease in one extremity. It's not necessarily a bilateral disease. Once it affects, it could affect one extremity. So we want to make sure that we're doing a comparison, comparing one extremity to the other to note the temperature differences. The patient may also notice that it feels uncomfortably cold. And so it's a cold that, you know, if we go outside and our fingers and our toes aren't properly covered, then we notice that cold. And if we don't protect those extremities from cold weather, then we're, you know, at risk for things like frostbite. Well, in this patient, it's a noticeable, uncomfortable cold. In addition to the extremity being cold, there's also going to be pallor or paleness associated with it. We normally have a pinkish hue to our skin, and well, that's because we have adequate blood supply. But in this person, the arteries are occluded, so this person has diminished blood supply, and so the area is going to be pale because it lacks blood supply. Also, when we apply pressure over that extremity, blanching occurs when the part is elevated above the level of the heart. But when it's lower than the level of the heart, blanching does not occur. We also may notice cyanosis, and cyanosis and pallor are different. Pallor is just the person lacking color. Cyanosis is an actual blueness associated with a lack of oxygen. And so when the person has a lack of oxygen, the circulation to that part, we know that circulation has been impaired when cyanosis occurs. As we already talked about, we mentioned the intermittent claudication, and we see the intermittent claudication happening as a result of inadequate blood supply. It's a cramping that occurs because blood is not flowing in adequate levels, in adequate amounts to that part of the body. But as we mentioned before, if this person rests, then the pain tends to stop, if it is indeed intermittent claudication. Necrosis can develop. It's a loss of viable tissue. It's noted first in the most distal parts of the extremity. So, for example, if a person has peripheral artery disease that's affecting the lower extremities, the most distal part of the lower extremity is going to be the feet. And the feet is commonly where we see arterial ulcers develop. And so we know whenever a person has necrosis, that's when the tissue dies. And typically with necrosis, the way we know an area is necrotic is because it turns black. And so we know that that tissue is no longer viable. It's no longer alive when it is necrotic. The person can also have atrophy, muscle atrophy, as a result of lack of blood flow. So if a muscle becomes smaller, then the person is not able to maintain their normal activities because of the atrophy or the shortening of that muscle. And again, we see that happening as a result of ischemia or lack of oxygen to that extremity. Now, when we note the pulse volume in a person that has peripheral artery disease, typically these patients are going to have a weaker pulse. Sometimes the pulse is so weak that we may have to use a Doppler, and that's an electronic device that we use to detect blood flow. And so in some patients, if the peripheral artery disease is advanced enough, we will not be able to palpate a pulse on that patient. But remembering how you rate a pulse would be important, and we know that we can rate a pulse on a scale from 0 to +4, 0 being no palpable pulse at all, and +4 would be a strong and bounding pulse. Also, we may note bruise in an area that is affected by peripheral artery disease. If you remember what a bruit is blood flow pushing past an area of occlusion. And so when you're auscultating over maybe a carotid artery, we're listening for a bruit. We don't want to hear a bruit. That would be an abnormal finding, but it's a swooshing, sorry, I have to demonstrate, but it's a swooshing sound that we hear as a result of blood pushing past an occlusion. And so when we're assessing our patient with peripheral artery disease, we want to auscultate over the arteries. We know we have a femoral artery and we have a popliteal artery. We want to auscultate over those areas to note if we hear a bruit in those areas. The capillary refill time, it depends on, you know, how pronounced the peripheral artery disease is. We would acceptable capillary refill is going to be less than 3 seconds. Abnormal or sluggish capillary refill, well, we know that's going to be more than 3 seconds. And so we know capillary refill is an indicator of peripheral perfusion and cardiac output. So if a person has a slow cardiac refill, then we know that the output to that area is diminished. And so it makes sense that in a patient, when we're assessing the lower extremities, we're going to assess capillary refill on the person's toes, and with the upper extremities, the person's hands. And so our collaborative care for a patient experiencing peripheral artery disease, well, first thing we want to look at is risk factor modification. We've talked about smoking being a cause of peripheral artery disease, so you know it will make sense that we want this person to stop smoking. We've talked about smoking causing vasoconstriction. Well, this person already has decreased blood flow because the arteries are sick, so we don't need vasoconstriction to also limit the amount of blood that's circulating to that lower extremity. So we want this person to stop smoking, and we know that there are different medications out on the market now that assist people with smoking cessation. Also, diet is going to be important. This person may need lipid lowering medications. Zocor is one that's mentioned in your book that's typically used to help lower cholesterol levels. Also, treating hypertension is going to be important. We talked about the damage that occurs to the vessels as a result of hypertension. We have damage that happens to the vessels that can affect blood flow, and also we know at the extreme end of hypertension, it affects the ability of the heart to beat effectively and contract blood throughout the body effectively. So we need to modify or monitor this person's blood pressure, and we talked about acceptable ranges. And with a person that's diabetic, we want that person's blood pressure to be below 130/80. Your book also talks about antiplatelet medications such as Plavix, which help with inhibiting platelet aggregation, which is going to be important in this patient when we have a lack of blood flow to the area. It's also mentioned that ACE inhibitors can be administered to patients with peripheral artery disease because they're going to increase peripheral blood flow. We know that if we're given an ACE inhibitor, it's inhibiting vasoconstriction. So we have dilation and we have an increase in blood flow by administering the ACE inhibitors. There are also medications that are mentioned in this chapter that assist with the intermittent claudication, the painful part of peripheral artery disease, and they mention and also pleatal, and these medications work by increasing vasodilation. The pain that the person experiences with intermittent claudication is because of vasoconstriction and the lack of blood flow. So these medications again are going to assist with the intermittent claudication by increasing vasodilation and also inhibiting platelet aggregation. So make sure you read that chapter thoroughly over the different collaborative care interventions that we would use for a patient that's experiencing peripheral artery disease. Exercise therapy is also going to be important for this patient. And so when we talk about enhancing arterial blood supply, exercise therapy is one of the mechanisms for enhancing arterial blood supply. With this patient, the patient would need to begin a prescribed regimen of walking. Walking is simple, but it's also a very effective exercise for the patient that's experiencing peripheral artery disease. We want the person to we want to encourage the patient to walk. We want them to set realistic goals, and the person is going to exercise and keep with their tolerance level. They would not want to cause themselves to be out of breath or in pain as a result of exercising. So we do want this person to begin their exercise. We want the person to rest whenever they feel pain, and also it's going to be important for this person to avoid a chilly environment. What chilly environments do for the body, they cause vasoconstriction, and so vasoconstriction again is going to will affect the amount of blood flow. So we want this person to again exercise with rest, and also avoid chilly environments. Foot care is going to be important. At the beginning of the chapter, it talked about the distal popliteal artery being commonly affected in diabetic patients. So if we're talking about a person having occlusion and they're not getting a good blood supply to that lower extremity, we know that if that person cuts their foot, if they do anything to that foot, they cut their toenail too short and they have a small cut, then this person can develop infection in that area, and these patients are at risk for developing necrosis and gangrene as a result of infections. So it's going to be very important for the not only the diabetic patient, but any patient with decreased blood supply to a lower extremity. They have to make sure that they're practicing meticulous foot care, making sure that they're wearing socks, making sure that they keep their feet moisturized to avoid excessive cracking. They need to wear clean socks. It does no good to wear dirty socks on your feet, because if you develop an infection, well, you're hosting bacteria in the dirty socks. So the person needs to wear clean socks. Always wear shoes, and avoid walking barefoot. Wearing tight shoes is not a good thing because they lead really small shoes are irritating to the toes and to the sides of the feet and can lead to skin breakdown in those areas. So we want the person again to make sure that they're practicing foot care. And your book talks about some different surgical procedures that can be done for a person that has peripheral artery disease. So again, make sure you go over that information. There's a procedure of percutaneous transluminal balloon angioplasty. And what this is the insertion of a catheter through the femoral artery. Once they insert that catheter, they go above the area of the occlusion, and they dilate a balloon, and what that balloon does is it cracks up that occlusion, and they have a mechanism of removing the plaque. We don't just let the plaque float throughout the body. There's a mechanism of catching the plaque that balloon breaks up, and so that's one way of relieving an area that has an occlusion. But as we know, if it's the person's lifestyle that led to them having a blockage, if there is not any type of lifestyle modification, then the person can develop a blockage again. So we want that person, if they're going to have surgical procedures done, especially, we want that person to practice lifestyle modification so that they won't develop any further blockages. With Buerger's disease is a type of acute arterial ischemic disorder. So with peripheral artery disease, I think more of that as being a chronic disorder, something that happens over time, because peripheral artery disease typically does not go away. Now with Buerger's disease, it can be something that that happens on an acute basis. And so the disease, as it says here, it's a disease that causes obstruction to the blood vessels of the hands and to the feet. And so with the causes, the incident, and the risk factors of Buerger's disease, it's typically seen on within patients. With Buerger's disease, this is a non-atherosclerotic disease. So we see the difference right there between Buerger's and peripheral artery disease, because peripheral artery disease is caused because of atherosclerotic plaques. So with Buerger's disease, we see Buerger's disease being highly associated with a history of smoking. And so we see another differentiation between Buerger's disease and peripheral artery disease in the age. We see that it affects younger individuals from 10 to 20 years of age, whereas peripheral artery disease tends to happen later in life. And again, the blood vessels of the hands and the feet are affected with Buerger's disease. So we said that it's caused because of a non-atherosclerotic. The reason that we see Buerger's disease develop, it says in your book that it's a type of arteritis, which means that it's an inflammation of the artery. And so as a result of that inflammation, again, the person cannot have blood to flow effectively through that area, but it's not a blockage. It's because of inflammation of that artery that's obstructing the blood flow. And so with Buerger's disease, it's again, I know I keep mentioning this, but it's typically associated with tobacco use. Something that your book mentions that helps to differentiate peripheral artery disease from Buerger's disease is the red blood cell count, and also noting the blood viscosity. It tends to be altered in patients that have Buerger's disease. So that is one way of differentiating peripheral artery disease from Buerger's disease. And also people that have Buerger's disease typically do not have diabetes mellitus, whereas we saw diabetes mellitus being one of the main risk factors for a person having peripheral artery disease. So again, we want this person to stop smoking. The clinical manifestations, again, that we see pain in the hands and feet. It can be acute, happen acutely, all of a sudden, and it is severe. It often occurs at rest. So again, we have a differentiation here, because with peripheral artery disease, rest helped the person with peripheral artery disease. But with the person with Buerger's disease, even at rest, this person is in constant pain. They complain of burning or tingling, pain in the legs, ankles, or feet when walking. Also, referred to as the intermittent claudication. This is often located in the arches of the feet for the person with Berger's disease, however. They may have skin changes or ulcers on the hands or feet. We see that with peripheral artery disease. But again, remembering with peripheral artery disease, we typically see it affect the lower extremities. The hands and feet may be cold. We may still see the pale red or bluish color again, because even though we don't have the plaque occlusion, we have an inflammation of the artery, which is still impeding blood flow to that area. The symptoms may worsen with exposure to cold or with emotional stress, and we already know what stress and cold do to a person's body. We know those are stress. With stress, we have the central nervous system that kick in that causes vasoconstriction, and cold temperatures also exacerbate vasoconstriction. So we need this person to avoid stress, but it's kind of hard to avoid stress when you're in severe pain. So the drug therapy that is mentioned for these patients, antiplatelet medications, channel blockers, adrenergic blockers, and also anticoagulants. We want to keep the blood thin and also vasodilate the vessels so that blood flow is getting to that area. The book also mentions a revascularization, which is rerouting blood back to that area so that the area does not die. There's no cure for this, but again, the goal is to control symptoms. We want the person to stop smoking. We need them to avoid cold temperatures and attempt to increase circulation by applying warmth and gently exercising the affected area. And we say gently because, again, with exercise, it's going to cause this person to have pain, and even rest is going to cause them to have pain. Again, with the sympathicotomy, this is a cutting of nerves to that area, and so it's going to help control pain in that area. But if somebody has the nerves cut to an area, they have to be really careful that they're monitoring that area for any cuts or any skin breakdown, because again, they won't they won't sense pain in that area, and that place can become infected, and they won't feel it or sense it because the nerves have been cut. Aspirin can be used as a vasodilator, and amputation of the extremity may be necessary if infection or extensive tissue death occurs. So our nursing interventions, again, we're going to prevent the progression of disease by having them to stop smoking. We want them to avoid vasoconstriction, keep them out of the cold, promote vasodilation, give them calcium channel blockers, give them apply warm compresses to the area that causes vasodilation. We want to relieve pain, and we also want to treat ulcerations and gangrene. With Raynaud's phenomenon, this is a general term used to describe a condition in which there is an increased or unusual sensitivity to cold or emotional factors. And Raynaud's typically occurs in the hands. It's unknown why it happens, and it may have a hereditary link. The condition can occur in ages 17 to 50, but is more common in women. And what happens in Raynaud's disease is it's a vasospasm of the arterioles and the arteries of the upper and lower extremities. It's usually unilateral, but Raynaud's disease occurs bilaterally. So the phenomenon is usually unilateral, which means it affects one extremity. However, the disease occurs bilaterally. And so what usually causes an exacerbation of Raynaud's disease or the vasospasm cold can aggravate Raynaud's disease, and what you'll see is that the person has a characteristic change in their colors, and it can affect the fingers, the toes, the ears, and the nose, and it will change from white to blue to red. And so what you're seeing and what you're noticing, as your book says, you have decreased perfusion, which causes it to be white, and the digits may appear cyanotic, which causes the blue color, and then these changes are followed by red, and this is a hyperemia when perfusion has been restored. So you have the vasospasms that are causing the vasoconstriction. Okay, so we have the area becoming pale because of the decreased blood flow. Then they become blue. Becoming white because of the decreased perfusion. And then we have the blue that happens because of the lack of oxygen. And then once the spasms decrease and we have vasodilation again, then the area becomes red because we have perfusion of blood. So treatment involves relieving or preventing vasoconstriction by drug therapy. And so commonly prescribed drugs that are used are Procardia. Procardia is a cardiac med, and Procardia is a calcium channel blocker that's going to cause vasodilation as a result of being administered. Our education of the client is important in prevention of complications. This person needs to minimize cold exposure, smoking cessation again, which causes the vasospasms, and they also need to decrease stress. I'll let you read over these things again, but it's just really a breakdown of what you see with Raynaud's phenomenon, the intermittent vasoconstriction resulting in the coldness, pain, and pallor, involvement of the fingers, appears to be asymmetric. The thumbs are less often involved. You have the characteristic color changes of red, white, and blue. The blue means cyanotic, white means blanching, the red is reactive hyperemia from rewarming, and occasionally there is ulceration of the fingertips. With occlusive arterial disease, this is a form of arterial sclerosis in which the vascular system of the legs become blocked, totally blocked. The clinical manifestations, again, much like peripheral artery disease, you have the tingling, color changes. This says decrease in leg size. Remember, we talked about the muscle atrophy, and so you have a shortening of that muscle. The person may have pain even at rest with occlusive arterial disease, and it occurs at night, requiring the client to get out of bed and walk to relieve pain. The person have cramps in the calf muscles, and ulcers of the toes and feet develop with occlusive arterial disease. Peripheral artery disease, we may be getting a little blood to that area. We've got an area of blockage. With occlusive, they're totally blocked, so the person is not getting adequate blood flow to that area. So with acute arterial occlusion, this is an onset that's sudden and dramatic, and this is the one that's typically due to an embolus. And so an embolus is anything foreign in the blood, and so an embolus, a person can have an air embolus. They can also have a plaque embolus, and we know that we've talked about that with atherosclerosis. So, and with acute arterial occlusion, this could be because of a plaque becoming dislodged from one of those arteries, and now it's occluding the artery. So the client describes severe pain below the occlusion, even at rest. The affected extremity is cool, cold, pulseless, and molted. Clients will often present with the 6 P's of ischemia, and this will be important for you to know: pain, pallor, pulselessness, paresthesia, paralysis, and poikilotherma, thermia, which means a coolness, and that also means that the extremity is taking on the temperature of the environment. So if the environment is cold, that extremity is cold. If the area is warm, then the extremity is warm. But you will be able to note the temperature differences between the two extremities. And so, again, we need to make sure that we're differentiating this from peripheral artery disease. Again, we said this is acute. So something acute happens all of a sudden. The person with peripheral artery disease, this is something that they're affected with every day. Okay, this person, it's a sudden onset. And so it's sudden, and we also notice the 6 P's associated with acute arterial occlusion. And so with arterial ulcers, we see arterial ulcers developing because, again, we've talked about a lack of blood flow to an area. So without blood, the area dies. And so initially with arterial ulcers, they're painful ulcers that develop typically on the toes, because we said with peripheral artery disease, the ulcers that develop, we typically see them developing distally first. And so the toes, and the upper aspect of the foot are typically where we see arterial ulcers develop. Prolonged occlusion without any type of surgical procedure, without any type of vasodilation, may cause gangrene of the toes. Of course, the toes are going to be cool and cold. We know they're going to have decreased capillary refill, and also atrophy of the skin. The person will also present with hair loss to that area. The treatment, we want to treat the underlying cause, and as it says here, surgical revascularization, and that's we're routing blood back to that area. We want to prevent trauma and infection, and again, we want to make sure that we're stressing foot care to this patient that has arterial ulcers. Because of that inclusion, they are at risk of developing infections to that area. So we've talked about the arteries. We've talked about peripheral artery disease, Buerger's disease, Raynaud's disease, acute arterial occlusion. So make sure, one thing you may want to do when you're preparing for this exam, make yourself a chart and put your clinical manifestations, put your nursing interventions, put your signs and symptoms. Some of the signs and symptoms may look the same, but what stands out for each one of these diseases. But we know with all of them, we've got a problem with the arteries, and so we've got blood flow being affected in all of them across the board. So we know that that's common to all of them. Okay, but your treatments differ with the different arterial diseases. So now we're going to talk about the veins, conditions of the veins, varicose veins. And so this is something the ladies, well, and men too, may want to pay attention to. This is the standard protruding veins that appear darkened or tortuous, and that's a thick, really thick protruding vein. It's common in clients older than 30 years of age whose occupations require long periods of standing, and so that is nurses. And so treatment involves wearing elastic stockings and elevating the extremity as much as possible. We know that typically nurses will wear the tight, the socks that are constricting, and that they force blood flow back to the heart. Okay, the constrictive hose. Surgical removal of the vein may be necessary when the veins are larger than 4 milliliters in diameter, or they are in clusters. And so with thrombophlebitis, this is a condition in which a clot forms in a secondary vein to phlebitis. Well, I'm sorry, y'all. A condition in which a clot forms, it's secondary to phlebitis, or because of a partial obstruction of a vein. Got it. So clinical manifestations of thrombophlebitis is a slight swelling around the ankle, obvious prominence of leg veins in the affected area. And so calf pain may be aggravated when the foot is dorsiflexed with the knee flexed, and this is what we would call a positive Homan sign. And so we check a Homan sign when we're doing our daily assessment of our patients to see if they have any inflammation of the veins. Again, we know that if we have an inflammation of the vein too, we have blood flow that can be affected to that area. And so, again, in your book talks about superficial thrombophlebitis, and it also talks about deep vein thrombosis. So make sure that you go over that information, and make sure that you can differentiate between the two. Page 909, table 38.6 tells the difference between superficial thrombophlebitis and deep vein thrombosis. With DVTs, we know DVTs are a problem when we have patients that are immobile, and so we have blood that's not being pumped effectively. So we know that we have to make sure that we're doing our range of motion on these patients that are in bed for a while. The positive Homan sign is also classic when a person has deep vein thrombosis, but as your book says, it can be an unreliable sign. And so along with the person, if a person says ouch when we dorsiflect the foot and they complain of calf pain, we may need to follow up a little bit more. Maybe they need some x-rays to be done, or some different Doppler studies to be done to determine if there is actually thrombosis in that area. And so with chronic venous insufficiency, this results from valvular destruction. It's a form of chronic venous stasis. It may be a residual effect of phlebitis. Again, remember, phlebitis is when that vein was irritated, it's inflamed, so it's not pumping blood effectively. Well, with the person with the arteries, we're not getting blood to the area. Well, with venous insufficiency, we've got blood in the area, it's just not being pumped back to the heart where it needs to be. And so with this chronic venous insufficiency, it results from chronic occlusion of a vein or destruction of the valve. So again, this person has blood, it's just not being pumped. Clinical manifestations would be pressure in the ankles much greater than normal. They're going to have stasis. Stasis means we've got something staying, and what's staying is blood. They're going to have stasis, chronic edema, discoloration. The lower extremity is going to take on a darker color as a result of blood pooling in that area. They're going to have recurrent thrombosis leading to cellulitis, and cellulitis is the inflammation of the tissue itself. And if the cellulitis is untreated, then the patient is at risk again for gangrene and possible amputation. The treatment is primarily non-surgical, unless it is complicated by a venous stasis ulcer, which is a chronic non-healing ulcer that requires surgical debridement. Edema is managed by wearing elastic or compression stockings. We have the compression hose, the SED hose that we put on our patient that are electric, that intermittently compress the lower extremities, so they're forcing blood back up to the heart, and the compression stockings do the same thing. And the legs should be elevated for at least 20 minutes 4 to 5 times a day. Now again, we know that this didn't help the person with arterial disease because the arteries, we're not getting blood down there. With venous insufficiency, there's blood. Again, I keep saying that there's blood there, but it's not being pumped back up to the heart. So by elevating this person's legs, we're helping blood to flow back to the heart, and by putting on compression hose, again, we're forcing blood back to the patient's heart. As you see here with a venous stasis ulcer, it's a venous skin ulcer, also called a stasis ulcer. It's a shallow wound that develops when the leg veins do not move back toward the heart, do not move blood back toward the heart, normally, and you have venous insufficiency. So what happens is, I keep saying it, but we have blood, and so you have this blood, and blood continues to pool in the area, and so after a while the blood has to have somewhere to go, so it comes out of the veins, it goes through the tissues, and it's tunneling out of the body, okay? And so the venous skin ulcers typically develop on either side of the lower leg, above the ankle or below the calf, and so the two types of occlusive dressings that are used for venous stasis ulcers are oxygen permeable or oxygen impermeable dressings, and the Duoderm is the typical type of dressing. Now, what I want you to notice when you look at that, look at the appearance of it. It's red, look at the color, and it's also wet. If you will go back to your chart on page 901, it gives the comparison of an arterial and a venous leg ulcer. A venous leg ulcer is going to be what we call a wet ulcer, and it's wet. It makes sense because we have blood to that area, and so this is going to be the wet type of ulcer, whereas your arterial ulcers are going to be dry, hard and dry, and again, it's because we have a lack of blood flow to that area.